Again, if I'm using one and I haven't spelled it out, please let me know and we'll make sure we clarify. Next slide, please. So today, again, just want to provide a brief overview of Community Health Choices, what the program is, what impact Community Health Choices may have across different populations that are served and affected by this new program. We can highlight some advocacy issues and efforts made by CARIE and consumers and fellow advocates. And I'm also curious, in past presentations with stakeholders like yourselves, I'm wondering how this may potentially impact your work as well. I know in SMP, if the topic of Medicaid fraud were to come up incidentally to any Medicare fraud investigation, there's the opportunity, of course, to report it to Pennsylvania's Department of Human Services. But I know some of you are also prize counselors. So I'm not sure for those of you that I know are just doing SMP if this otherwise does come up. I see Dan asked a question about my video. Fortunately, I'm having some technical difficulties today. So to give you some context, I've got some nice tulips on my desk. The sun is shining, and due to some recent car alarms that are going off, I've got my window closed. So if there's any ambient noise, let me know and I'll try to minimize it here. Before we get started, I just wanted to quick poll this group here. I guess not necessarily how familiar are you with Community Health Choices, but does this come up in your work with any regularity? It could just be a show of hands, or if any of you want to offer more specific comments, I just would love to hear from you all briefly before we really get started.
I probably 40% of my clients either have it or should have it. And there are issues that come out of that very fact. Thank you.
And Peter, are you a prize volunteer as well?
Yes, I'm a prize. Yes.
Excellent.
Western PA.
Western PA, great. Thank you.
This is John Vogel, same thing. I'm an prize counselor and here up in Berks County, and the little extra area I cover, it comes up all the time. Mm-hmm. And there was some confusion with consumers on it. And you are correct, David, it takes a little bit longer to explain it to them.
Sure. Thank you, John.
David, this is B. I'm in training with a prize, and already during training, it's come up. So it's clear to me I've really got to learn as much as I can about it.
Sure. Thank you, B.
I mean, as you know, I'm a prize counselor at CARIE. So we have the advantage of having David on the staff. So if the question gets complicated, we just ask David to call him back.
Thank you, Dan. And always glad to speak with people. Well, great. Thank you all for sharing. And I actually wasn't aware of how many of you are also a prize volunteers, which is wonderful. Thank you. I, of course, am a prize volunteer myself, but I do briefly touch upon the impact Community Health Choices has on those that are duly eligible. So maybe that's something we can talk about with a little bit greater detail, not just how specifically they work together, but kind of how the program is interpreted by consumers, and how specifically as prize volunteers or just advocates, we can help consumers parse this change to Medicaid. Next slide, please. So first and foremost, let's just do the bare bones overview here. So Community Health Choices is Pennsylvania's mandatory managed care program that was a dramatic change from the previous fee-for-service Medicaid system. It's a program in which managed care organizations which have contracts with the state are paid a capitated rate, a per member per month rate for Medicaid services. Now, these Medicaid services could simply be Medicare cost sharing for those that are community well dual eligibles, or they could also be paying for some long-term services and supports as well. Community Health Choices, or CHC henceforth, is a relatively new program. It was implemented in 3 phases between 2018 and 2020. So as of today, in 2021, the program is fully implemented across the state. There's no longer certain pockets of the state that have Community Health Choices and other pockets that have fee-for-service Medicaid. Despite being fully implemented, very much would still treat this as a relatively new program. and certainly some growing pains that are associated with it. That being said, we'll talk about some of the progress that has been made by advocates and beneficiaries. So community health choices does include adults 21 and older that have Medicare and Medicaid, regardless of whether they are clinically eligible for long-term services and supports. Community health choices will also serve individuals who have Medicaid only that qualify for long-term services and supports. As I mentioned previously, instead of a fee-for-service program administered by the state, managed care plans, insurance companies, they're the ones that are administering long-term services and supports. This includes care received in a nursing home or waiver services. Waiver services being a range of long-term services and supports that someone can utilize in-home, in the community to maintain independence and autonomy and to have their care needs met. There are 3 community health choices plans across the state. In the Philadelphia area, there's Keystone First Community Health Choices. Throughout the rest of the state, the plan is called AmeriHealth Caritas Community Health Choices. So depending on where you are, you have the choice of either AmeriHealth Caritas or Keystone First Community Health Choices. The other 2 plans available statewide are Pennsylvania Health and Wellness and UPMC Community Health Choices. Individuals, when enrolled in Community Health Choices and as active beneficiaries, they have their choice of one of these 3 plans, and they can change these plans at any time. Emphasizing that Community Health Choices is not the Health Choices program. Health Choices is the name of the Medicaid program that provides physical health benefits for adults. We'll talk about some of the challenges this can pose when we talk more about Medicare and Community Health Choices. But for now, just really emphasizing that Community Health Choices is a different program from Health Choices. Life programs are excluded from the Community Health Choices program, which is mandatory. If someone qualifies for life and there's a life program in their area, they can choose to receive services through the life program instead of Community Health Choices. Next slide, please. Again, diving a little bit deeper, we mentioned Community Health Choices is for people 21 and older that are dual eligibles, have Medicare and Medicaid, or are receiving Medicaid funded long-term services and supports, whether or not they have Medicare or not. Let's quick breeze through these. Not included in the CHC program are life participants, residents in state veterans homes, and those partial duals, QMB, SLMB, and QI1. If someone is not receiving full Medicaid and they only get, their Part B premium paid for by the state, they would not be included in the Community Health Choices. Next slide, please. The benefits in the Community Health Choices program, physical health, behavioral health, pharmacy, and LTSS. Now, granted, the vast majority of people enrolled in the Community Health Choices program are duly eligible for Medicare and Medicaid, and their primary insurance will continue to be Medicare. But for those that have Community Health Choices only, they do get the adult benefit package in the Medicaid state plan, meaning they can, of course, see doctors and specialists and get all the benefits included therein. Behavioral health. Behavioral health is an available benefit, and it is offered by a county-specific behavioral health managed care plan. Separate program, but for those who are eligible to receive these services under Community Health Choices, they are coordinated by their Community Health Choices managed care plan. Pharmacy benefits, similar to the physical health package, this is specified in the Medicaid state plan, and for those that do have Medicare coverage, that'll continue to be the primary payer. And lastly, long-term services and supports. There are many long-term services and supports. I believe there's upwards of 30 or so. I'd have to double check. But this includes things like nursing facility services and home and community-based services. Home and community-based services can include personal assistance services, getting help from an in-home caregiver, can include some transportation benefits, nursing home transition, home modification, these types of things. Next slide, please. wanted to briefly talk about actually applying for community health choices. The application process will look differently depending on what level of community health choices, for lack of a better term, someone would be applying for. Generally speaking, of course, consumers that are interested in getting CHC coverage, they must meet the financial and/or clinical eligibility criteria. So in 2020, the income and resource limits are listed here. So if someone is just applying for full Medicaid, they don't qualify, for waiver services, or otherwise not interested in applying for them, the income and resource limits are going to be lower. If someone is applying for waiver services, as we likely know, the income and resource limits are higher. If someone's applying for waiver services, it's a multi-step process, and it's not the easiest as well. And perhaps this is something I just saw John kind of shake his head, so maybe we're kind of underscoring it here. But generally speaking, here are the steps. Pennsylvania has an independent enrollment broker, which currently is Maximus. They are responsible for helping someone from start to finish through the application process here. So if I'm an individual who's looking to apply for waiver services through Community Health Choices, or I'm trying to assist someone who is, first and foremost, they can contact the independent enrollment broker. They will start the application process and kind of get the ball rolling here. The second step will be an initial visit by the PA-IEB. Typically so I guess I'll bring this up now. Many things, of course, have changed and have adapted due to the COVID-19 pandemic. And we'll talk a little bit about what some of the flexibilities that have been afforded. And I'll try to toggle back and forth with how things typically operate and how they have been because of COVID-19. This initial visit is typically done in person, but can now be done telephonically as well. During this initial visit, a representative from the PA-IEB is going to talk about the application process, what the different benefits are, whether it's through Community Health Choices or through the LIFE program, and start the process of completing necessary paperwork. This is where someone's going to get a copy of the PA-600L, the lengthy Medicaid application, and start getting that completed and submitted. During the second visit, someone's going to undergo a clinical assessment through what's called the Functional Eligibility Determination, or FED. This is where someone undergoes a clinical assessment and they're given a decision as to whether they're nursing facility clinically eligible, NFCE, or nursing facility ineligible, or NFI. If someone disagrees with this decision, they do have appeal rights. The IEB is then going to review that FED assessment, that piece of the clinical eligibility determination, and also gather some other necessary forms as well, which would include a physician certification as well. Lastly, this clinical eligibility is then kind of synthesized with work done by the county assistance office, in which they review the application and also determine financial eligibility as well. This is when they start looking at bank statements, looking at resources, which can be a barrier in and of itself. A decision should be made within 90 days from the start of the application, though there certainly have been delays. And if any one of these steps, which are already quite abbreviated, if there's a hiccup, this can, of course, delay things. Most common one I come across, of course, is missing bank statements, which can be very challenging to access, especially if someone is not tech savvy. And online banking, of course, may be the easiest way for us to print 5 years of bank statements. And I've been on the phone with different banks that are charging multiple dollars, per page of bank statements. So if you've got someone who's nearly definitionally low income, who's applying to get much needed relief with something like Medicare cost sharing or types of services that are already very costly, those few dollars per page for 5 years of bank statements can really add up. John, I saw you raise your hand briefly. Do you have a question? I believe you're on mute. My lip reading isn't.
There you go.
Particularly
there you
good.
go. There you go. On the initial visit, when it changed over because of COVID to the phone, I had a couple of people that asked me that they were told that the person who was answering the question, did they have permission to actually answer the questions? And if they if they didn't, could they supply a form saying that they're going to give them permission to answer the questions? And that turned into a little bit of a problem, because if you don't have on file I'm trying to remember the name of the actual document, but it's the permission slip that says, I can answer for you. Yeah. Even though the person was sitting there, but that turned into being a little bit of a hiccup because of not being able to physically be there, but because it was being done by phone. Have you run into that, and what's the answer?
Yes, I've run into that. So given the nature kind of our work, both in the apprise and also the CARIE line, troubleshooting issues, I myself have run into that permission problem. What's the solution? There isn't a particularly good one. If it's required to get that HIPAA authorization form, I respect that they need it, even though it can kind of jam up an advocate like ourselves trying to help. Fortunately, don't really have a good answer. In the cases, how we've resolved it, I personally am working remotely. Some of my colleagues will periodically pop into our office in Center City. I haven't taken the plunge yet and haven't bought an office printer yet that's got fax and scan capabilities, but we've just had to complete those documents. Unfortunately, this has kind of delayed things, often upwards of multiple days. Depending on the severity of someone's need for these services. We talked about this 90-day decision time frame. Some people are applying for these services a bit more proactively, thinking I may qualify now, but there isn't an imminent or urgent need. But for those that maybe they should have applied a few months ago, but faced some barriers that prevented that, or were not aware that these services existed, yeah, it's a problem. Definitely an ongoing pain point, and it's unclear to me exactly what the advocacy can be, but I'm glad to, please, hearing from you and you're experiencing similar problems may prompt me to kind of revisit this and see what type of solution we can come up with.
Yeah, I tried to ask the IEB and see if there was a basic standard answer, but the answer I was given, it was as quickly as that form can be filled out and submitted. But most of the people that I was dealing with, like you, do not have fax, do not have any way of getting it. So it was mail. So they were adding another 10 days just because of all the difficulties that's going on. So I was just wondering if that particular issue, because of COVID, if we couldn't address it in some way that could speed up the concept. I'm not sure how it could be done.
Yeah, it's a good question. You're absolutely right. Compounded, all of this is compounded by mail delays, which has rippling effects for other aspects of community health choices services, which we'll briefly touch on. But appreciate the comment. Thank you. Yes, Peter.
I'm curious about we're talking about the answering the questions for the CAO or questions for the Pennsylvania IEB. I'm just confused about that. But I always direct patients or clients, rather, beneficiaries, to make those calls themselves directly. I used to be in an office, and before COVID, and we could make those phone calls and they could always speak for themselves and I would coach them as necessary. But now I'm giving them the numbers and say, you have to make these calls.
Right. We were talking about the IEB has a process, a mechanism by which, oftentimes it's, a family member, assisting an applicant, to be present in these conversations, to answer some questions. Yes.
I'm sorry, but are you saying that if the beneficiary themselves and a family member is there, that the beneficiary is unable to verbally authorize their involvement?
So I myself, in the work I do, I'm not present physically at these visits by the IEB. John, I'll let you certainly speak for yourself. My involvement is typically when a family member, will call me, and the family member themselves may not be an approved authorized representative. And of course, this is
Right.
typically a situation in which the applicant themselves may be in circumstances like they could be hospitalized, which the family member is trying to cobble things together remotely,
Right.
or they could be perhaps incapacitated but may not have been, assigned a guardian yet. Could be kind of in that process. So yes,
Right.
at least for me specifically, the pain points are pretty situational.
Yes.
John, I'm not sure about your experiences.
Mine basically have been the concept that someone could not, it wasn't that they couldn't verbalize or they could not understand what the question was, either from a language standpoint or from an ability standpoint. And they were actually turning to whoever was sitting next to them. And the interviewer was saying, we do not have on file John Vogel as an approved HIPAA person who can answer this question. And they would just close it down right then until they got the form. And that's what was going on. It was about 3 or 4 people. And it was not a language thing. It was more an understanding thing, that the person being the actual applicant was turning to someone else and trying to figure out what they were being asked. And that turned into being a problem.
And these HIPAA authorization forms are required for all types of health insurance, Medicare, things of that nature. My experience is sort of a mixed bag. I know if I call an insurance company with a dental question or a health question on my wife, usually my wife can just verbally allow me to get the information. But obviously it varies across the board. Some insurance companies will go with the verbal. Some companies want the form. Some companies will go verbal initially, but mail you the form, and they want the form for subsequent inquiries. So I find it's pretty much a mixed bag with respect to requirements.
I believe, Bill, that Maximus within itself says they need the form on file to protect themselves from federal law.
That's probably bullcrap, but yeah.
But could be.
I don't think the federal law says you have to have something in writing. And obviously there's a form to use, but I know when I call, probably half the insurance companies I deal with will initially accept the verbal approval from the person sitting or on the phone with you, and then they'll fax you or mail you the form for completion for subsequent communications. But it varies.
Well, we'll move on momentarily, but yes, the IEB does seem to be on the more conservative side. But this is I haven't really prompted the IEB with this question in a while, so this is a good note for me to take back. So thank you all. Next slide, please, Dan. And this is a much simpler slide. Someone just applying for Medicaid, Healthy Horizons. They can complete an application by phone, online, mail, or in person at the county assistance office. So Compass, they can complete a Compass application or online, or they can get started by contacting the DHS helpline. While there are fewer steps, this does involve, of course, collecting bank statements, which for me has been the most challenging part to assist consumers, again, especially if they don't have online banking. And obviously COVID has made this certainly a bit more challenging for a number of folks as well. We'll move on to the next slide. We'll be talking a lot about some early lessons and tips for some specific topics throughout this presentation, but just high level. Again, this is a program that completed implementation in 2020. It's also a program that has spent a year under COVID-19. So a lot has been learned. Especially for this audience, we can just right off the bat say the relationship between Medicare and Medicaid is confusing and complicated. That's an understatement. And it continues to be a challenge for consumers that have Medicare and Medicaid and CHC. When I say challenges, something that has, I think, happened less and less are billing errors or billing mistakes by Medicare practices. I still hear them, don't get me wrong, but when this program was implemented in Philadelphia in 2019, they were ubiquitous. An uncertainty as to how these plans could be billed, what the billing rules were, whether someone needed to have a Medicare provider that was in network with their CHC plan. That'll still come up. and the plans themselves are still doing education as well as professional societies. So while it still is a problem for some providers, seems to be happening less and less frequently, which I would say is to be expected. I think for consumers, however, this is still a big challenge. We'll talk specifically about the, I think, particularly fraught transition from Medicaid only to Medicare and CHC. I say fraught because these are just naturally complex systems, and there is no one singular source kind of synthesizing what everything means for a consumer, but we'll talk more about that momentarily. COVID-19 obviously has been a huge challenge for this program. We have beneficiaries who are on a daily basis, receiving in-home services and supports from direct care workers. So living in a pandemic, with a respiratory illness that's highly communicable, it's been an enormous challenge for consumers to, routinely and reliably get the services that are in their person-centered service plans, while also making sure that direct care workers getting reimbursed through the system also are protected as well. We'll talk a little bit about what the Office of Long-Term Living has done and the managed care plans have done to kind of adapt to the evolving needs of consumers and providers under COVID-19, and kind of what that means for consumers moving forward. Nursing home residents are included in community health choices, and there continues to be some confusion as to what exactly the program does for them. What their current plan is, who their service coordinator is, which is relative. It's a kind of a new person involved in their care team to some extent, how to access services and more. The long-term care ombudsman, and for those of you who are unfamiliar, there are some staff on CARIE who serve as long-term care ombudsman for a good part of Philadelphia. They've been relaying some issues and concerns and questions from skilled nursing facility residents about kind of what CHC means for them and kind of what gaps there are. So we are advocates, and the Office of Long-Term Living is overseeing the implementation and steady state of this program. They've been fairly responsive to issues that may come to our attention or fellow advocates, especially if there's an immediate threat to someone receiving care. They've been responsive to some broader, stickier issues as well, involving complaints and grievances. We talk to them a lot about service coordination. But fortunately, there are open lines of communication with the Office of Long-Term Living to talk about the experiences of consumers and advocates. Big question worth posing is, will community health choices managed care plans focus on the medical model and medical necessity versus the social model and the participants' goals and quality of life? We'll talk a little bit more about the resumption of service reductions for those receiving long-term services and supports, and the program is designed to afford individuals the services and supports that they need to thrive and live safely and independently. But with the managed care model, being paid per member per month, there's certainly the question of how services are being administered, even though they're through standardized assessments, and it's something certainly to continue to monitor to ensure that consumers are getting the services that they need. Now let's talk a little bit more about some specific areas of interest. Next slide, please, Dan. So right off the bat, let's address COVID-19. So currently, we are in the middle of a federal public health emergency declaration that is currently set to expire on April 20th. This has been extended a number of times. It's unclear whether it will be extended again. As of today, what this means is that there will be no Medicaid terminations due to any of the eligibility criteria until at least April 30th. If this gets extended, that likely will change, but fortunately for approximately the past year, individuals have benefited from the protection that their Medicaid services cannot be terminated unless they're deceased or they willingly disenroll from the program. So hopefully this public health emergency declaration is extended, even though we are optimistic about growing rates of vaccinations. This is an important protection for consumers during this. As John was mentioning, while vaccinations are increasing, so are some case counts in certain counties. At the beginning of the pandemic, there was a moratorium on long-term service and supports service reductions. Effective July 2020, these reductions were permitted to resume, provided that the reductions were based on recent and in-person assessments. So currently, individuals are have been getting notices that their services are being reduced, or that their request for new services are either being denied in full or being partially approved, which is also a denial as well. On these denial notices, there are notifications as to what an individual's appeal rights are. And if you do come across an individual who has gotten a service reduction, they can contact statewide Pennsylvania Health Law Project. There are other legal aids throughout the state that are assisting, and in Philadelphia, they also can reach out to community legal services. We can provide at CARIE and the Apprise program, we can provide some general information as to what one might expect through the grievance process, the different levels, but if someone is looking for legal advice, there are free legal aids that can help. And lastly, we can talk about the Appendix K waiver and the subsequent amendments. The Department of Human Services, Office of Long-Term Living, they've submitted and obtained CMS approval of Appendix K waiver amendments. This allows for flexibilities in certain areas. Policies have been adjusted and readjusted as the state, in addition to the managed care plans they've have worked on to respond. Some of these temporary changes we've seen this year include, as we mentioned previously, the independent enrollment broker, their functions at times can be completed telephonically. Same can be said for service coordinators doing much more of their work telephonically as well. Functional eligibility determinations, some of these functions at times can be completed telephonically. As we mentioned, there was a period in which LTSS services could not be reduced, and the availability of personal protective equipment for both consumers and providers became more available. Adult day health care has been permitted to be provided virtually, though we have not seen that operationalized to a very large degree quite yet. Obviously, outside of community health choices, we know that individuals who are receiving care in congregate settings like adult day programs, obviously the pandemic has been very disruptive for them. Home and community services can be permitted in alternate settings as part of a nursing home transition strategy. And there have been some changes in the Bureau of Hearings and Appeals processes. The Appendix K waiver has had multiple amendments through the past year, and we'll likely continue to see some changes and flexibilities as hopefully we are easing out of this pandemic. But I guess the takeaway point is obviously COVID-19 has been quite disruptive, but certain flexibilities have made individuals receiving care and also providers in the system be afforded a little bit more protection, whether it's in terms of, service reduction moratoriums or even something as simple as the greater availability of PPE. Next slide, please. As I mentioned, let's talk about community health choices for people that have Medicare and Medicaid. Excuse me. First, we can talk about dual eligibles that are not receiving long-term services and supports. So their Medicaid, in some ways, is just kind of operating to largely pay for Medicare cost sharing. Medicare continues to be the primary insurance, and a person's CHC plan is responsible for Medicare cost sharing. A point to drive home with this group is that a CHC plan is responsible for Medicare cost sharing, even if the Medicare provider does not have a contract with the managed care plan. I'm sure this is known to many of you, if not all of you, but worth emphasizing the point that the community health choices plans, the managed care plans, they have contracts with providers all over the state. There are individuals in the community health choices program that do not have Medicare, and their CHC managed care plan is their sole and primary insurance. Like other managed care plans, like Medicare Advantage plans, they need to see providers that are in network. So a common issue we would come across, of course, is someone who's a dual let's say for, let's say they've just got fee-for-service Medicare, original Medicare. Their doctor will say, of course, we accept assignment, we take your Medicare coverage, but your CHC plan isn't in network with us. So you need to change your CHC plan to this other one. Provided someone's going for a Medicare covered service and the provider accepts their Medicare coverage, the CHC plan is responsible for Medicare cost sharing, whether or not they have a contract with the provider. This comes up a lot. How it's resolved will vary. Some providers, and I would say this was much more common, I'd say a year or two ago, is the providers were really unsure how this program worked. And a simple phone call or a consumer printing out a fact sheet from the Office of Long-Term Living that said, yep, cost sharing is permitted and you just have to call the plan even if you don't have a contract. That may have been enough to resolve the issue. Sometimes it still happens now. And again, the intervention is largely the same. Sometimes the consumer can simply print out one of these fact sheets or I can mail them to them. I've conference called with billing offices with them, or the consumer can also kind of punt to their CHC plan and tell them, I went to my PCP, Dr. Johnson, and he's giving me grief for my CHC plan. And they're trying to, foot me with the bill. The plan themselves can kind of sort that out. Just as a brief pause, given how ubiquitous this problem was, and I know I've spoken about this with a number of you, has anyone continued, I'd say within the past 6 months or so, had some Medicare, Medicaid billing issues that kind of resulted from either confusion or lack of understanding?
I just worked one out over this last 10 days or 2 weeks. And because I knew that CHC was secondary, I just pushed the issue and the beneficiary actually was able to resolve it by making a couple of phone calls directly.
Right.
And the beneficiary was not conscious enough to use, always show the CHC card. That was part of the initial problem. But it's been resolved and I'm happy.
Yeah, in my experience, the issues arising do seem to be fewer in quantity. They also do seem easier to resolve. I'm just thinking 2 years ago in early Philadelphia implementation stage, I'm thinking of some phone calls I had with providers' offices that were as obstinate as can be and just refused to accept any change in billing practices or guidance. But that seems to be less and less common. Dan, I see you've got your hand up.
Yeah, just a little bit off that area. Do you know roughly what proportion of the dual eligibles are in D-SNPs versus original Medicare? And second of all, if you're advising somebody, I mean, this is a challenge that I've dealt with. I'm not quite sure whether you think somebody is better off choosing an aligned D-SNP or just staying with original Medicare. I mean, my feeling is just stay with original Medicare. Why bother with the D-SNP? Because if you join a D-SNP, you're limited to the network of providers in that Medicare Advantage plan, where original Medicare can go to anybody who accepts Medicare. But I guess that's what, do you have a rough idea of, the proportion of people that make one choice versus another? And maybe more importantly, what you would advise somebody who, a client just says, well, okay, what should I do?
To answer your first question, yes, more than just a rough idea. Give me 1 second and I can put in the chat for whomever is interested. The Department of Human Services does post a lot of data, and they do know this. They have Medicare type percentage by zone. There are different zones throughout the state. I pulled it up right now. For whomever's interested, I just sent a link from DHS. It's on page 5. Pockets of the state, I know outside of the major metropolitan areas, fee-for-service is very common, and then you can kind of take a look at the other data. To your other question, what would I advise? Well, we know with the Apprise program, we're providing them information as to what their coverage options are. To that point, we can highlight this second bullet point on the left side of the screen here. Consumers can choose any type of Medicare coverage they want. And if that does, lead them to a Medicare Advantage plan, or even more specifically, a D-SNP, they do not need to choose the aligned D-SNP for their Medicare and CHC plan. In terms of what would be advised, right, we can talk about the relative advantages of both fee-for-service Medicare and Medicare Advantage plans. If someone highlights, dental and vision as a goal or priority of theirs, we can talk about the lack of coverage under fee-for-service Medicare and talk about what might be available in different Medicare Advantage plans. In terms of, if someone asked me point blank, should I choose the aligned D-SNP or not? It's a challenging question to ask, because there really shouldn't be any difference in terms of, the care that they would receive. Speaking more anecdotally, and this is not something that I would kind of bring to an Apprise consumer, I've got someone I've worked with quite a bit who has had a number of different issues over the past year with different Medicare and Medicaid plans. But during a specific period, he had some trouble with billing issues, dental practice, and he did have an aligned UPMC Community Health Choices CHC plan with the UPMC for Life D-SNP. Now, I'm not saying that these issues weren't ultimately resolved, and this obviously is anecdotal, but a point I'll be making in the next slide, which we can talk about now, is precision. This is a consumer who is fairly well versed in kind of what coverage he has and the differences between Medicare and Medicaid. But how easy it is to kind of fall into this trap of saying, do you accept UPMC? And that was kind of an issue that he ran into. If I recall correctly, they had a contract with the D-SNP, but not the Medicare Advantage plan, which was surprising to me. You would think they would be aligned, but not necessarily. Similarly, if someone says Keystone First, or I have Keystone, that could mean Keystone 65, or Keystone First Health Choices Medicaid, or Keystone First Community Health Choices. There are purported advantages to aligned D-SNPs, which they will tout as having one company manage your Medicare and Medicaid benefits. Again, speaking to you all anecdotally, as a consumer, when I did call the Medicare Advantage D-SNP, they did have access to, call center records on the Medicaid side. So that was helpful. But there can be some pitfalls as well for someone who is not very precise as to which plan they may be talking about with, a receptionist at a doctor's office. John, you raised your hand?
Yeah, the issue I ran into was on the duals, like in Berks County, we're UPMC. And they came to Philadelphia for care for a specific reason. The one I'm thinking about right now is Will's Eye. And they really had a serious issue about trying to figure out how to get the bills paid. They were dual Medicare and UPMC. It took a long battle, almost like you, Peter. It took a little bit of time to really explain to everybody how that worked. But my question really is, when it seems to be crossing over a border where one particular of these MCOs is more popular versus something like I have, UPMC. They don't seem to mesh as easy as what I would think from where we are right now, from the beginning to now. But I run into that more than I'd ever like to, simply and solely because the person is basically, and this is a loose term, going out of network.
Sure, I heard. Can you rephrase the question? I'm trying to better understand it.
When you have somebody who in Berks County we have UPMC as the major, but they get
The major,
treatment.
I'm sorry, the major CHC plan or the major?
Yes, CHC, UPMC,
Got
okay? Dual eligible, and they're going to go to Philadelphia for care that the doctor thinks they need to go to. And there seems to be a lack of coordination of being able to get the billing straight because UPMC is not the primary CHC in Philadelphia. And I've run into all kinds of billing questions there. Took a long time to straighten them out.
Sure. So this sounds like it could be what we were talking about earlier, where for your consumer in Berks County, sounds like they're going to Wills-Eye in Philadelphia, and Wills-Eye accepts their Medicare coverage. But yes, there was leave it to hospital systems and insurance companies to have a blood feud over contracts. So it sounds like UPMC CHC still does not have a contract with Wills-Eyes, but that should not prevent approved Medicare cost sharing. So it sounds like what you're talking about is, at this point, Wills-Eye, they know the billing practices, but I've heard practices almost bully people into changing their CHC plan because they didn't want to deal with however those, billing machinations work between CHC plan and health system. How does that get resolved? That's a tough question. And some consumers, in my experience, have different levels of fight in them, which I understand. First and foremost, we can reinforce what rights the consumer has. Despite, these billing issues that arise, we can tell them the letter of the contract, which says UPMC is responsible for cost sharing, and Wills-Eye has every means available to them to get that money from UPMC CHC, even if they don't have a contract. So first and foremost, we should reinforce what their rights are. We also can try to, make a first level pass at trying to resolve it. I've spoken with some consumers who they stated themselves that they understand what their rights are, they understand how the system should be working, but they also don't want to deal with this. So they've changed their CHC plan to one they have, a contract with. Some people, when they change their CHC plan, the effect may be somewhat negligible. Given that for a dual, it's their secondary coverage, and especially if they're not getting long-term services and supports, they may not be using their CHC plan for much apart from Medicare cost sharing. Now, if someone is a full dual and they're also getting long-term services and supports, that change of CHC plan could be much more consequential. Things like home health care agencies and other LTSS providers are in-network and contracted providers with the CHC plans. So back to your original question, sometimes there is really no easy answer, but that's kind of how I cycle through it with consumers and kind of gauge how willing they are to kind of be involved in a possible fight. But I also try to offload it to the provider and the plan as much as I can, saying to the consumer, if you get a bill, don't pay it, let your plan know, and they should be able to figure it out.
Well, when you're dealing with people who are close to 80 years old, they get a bill, they're going to pay it because they're so afraid, the fear factor. You're right. They don't want to fight. They want me to fight for them, which I'm more than willing to do. But at the same time, I can't tell you how many, Dave, have said, well, I've paid the bill. Can I get my money back?
Yeah, it's shameful. It's almost a blessing when someone says, I got this bill and there's no possible way I can afford it. So I'm like, great, so you didn't pay it. And let's kind of figure this out on the back end. But yeah, I hear what you're saying. And fortunately, at least in my experience, this could be different in your county. These types of billing issues seem to be lessening in quantity, but certainly they still do exist and more work needs to be done. Absolutely.
Yeah, it doesn't seem to be, inside the county seems to be okay. It's when somebody goes out of the territory for services, that's where the problem comes up to be more of a real issue.
Interesting. Do you know in Berks County, the health systems, do you get a sense that they have contracts with all three of the CHC plans?
Well, we have a Tower Health with the UPMC plan. They're supposed to be in the boat with everybody.
Okay. Yeah, maybe that's why. That's interesting. Thank you for sharing. In the interest of time, I think I'm going to move just with a little bit quicker pace, especially if we have questions towards the end. Dan, do we have a hard cutoff here? I want to be respectful of everyone's time.
We don't. We have the Zoom link is live for 2 hours. I doubt we'll take up that whole time, but
I think I should be able to wrap up within about a half hour so we can go on and enjoy the rest of our day. Next slide, or I'm sorry. I want to talk about consumers getting long-term services and supports as well. So again, emphasizing that they can have CHC with or without Medicare. If they have Medicare, CHC is their secondary, and their LTSS providers, their Medicaid providers will need to be in network. Service coordinators are technically supposed to be responsible for coordinating available services, whether under Medicare or Medicaid. But as we'll talk about, service coordination is a real big problem under the CHC program. And we'll get into greater detail on that. Next slide, please. This is a passion project of mine. I think the transition from HealthChoices Medicaid to Medicare and Medicaid is extremely challenging for a lot of consumers just because of how confusing it is. We can spend, I think, a whole hour on this. I'll try to go through this quickly. So if someone is eligible, financially eligible for Medicaid, they've got a HealthChoices managed care plan. These are health partners. I think Cigna has one. Keystone First is the name of the HealthChoices plan. Again, this is a managed care plan, just like a Medicare Advantage plan, where people are getting their physical health benefits and their pharmacy benefits through one managed care plan. If someone is collecting, on Medicaid and they're collecting SSI, when they turn 65, they'll become eligible for Medicare, and everything changes. And many people have a very difficult time kind of understanding what exactly that means. And I attribute this largely to technically accurate, though kind of too precise for its own good, because it ignores the big picture of how someone's benefits are now coordinating with one another. So if someone is receiving Social Security and they were Medicaid eligible and they turn 65 and become eligible for Medicare, they should expect a number of things in the mail to be notified of. First, of course, would be termination of coverage from their HealthChoices Medicaid plan, which sometimes can be a problem. I had a consumer this past year get a notice from their health partner's HealthChoices Medicaid plan that was outdated. It was dated 2018, we can see on the bottom. The consequences of such were there's no mention of community health choices. It was still referencing, the state's Medicaid fee-for-service program as, the provider of services. And the consumer's impression from this letter was, I'm losing my insurance. What do I do? So again, we're talking about mail delays. If you get one letter from your HealthChoices Medicaid plan that says, hey, at the end of this month, you're done with us, and someone is not really too hip or savvy to, a Medicare initial enrollment period, or that, there's another Medicaid program by a different, though similar name, can be challenging. In terms of what other letters they should get, assuming that they, again, are already receiving Social Security, they'll get a notice of automatic enrollment into the low-income subsidy or extra help program, as well as a Part D plan assignment, unless they have made an affirmative choice themselves. They'll get confirmation of community health choices enrollment and coverage from the independent enrollment broker. And of course, they'll get their Get Ready for Medicare packet from CMS. I plug a prize here, and certainly the CARIE line as well. For many individuals, having that one HealthChoices plan, which was their sole insurer, and they got their PCP took it and their pharmacy took it. Piecing all these things together that we know, Medicare's primary insurance, depending on your coverage options, you might have a standalone Part D plan or maybe bundled together with the Medicare Advantage plan on top of community health choices literature, which does not always take the greatest care of differentiating what the benefits are for a full dual versus Medicaid only. All of this can be a mess. So if this does come up, I hope people do reach you at a prize. It's on my docket to create a kind of a fact sheet that takes the information on this slide and kind of breaks it down for everyone as kind of a singular, here's everything you should expect, here's what this means for you, and here are the resources that can help. When available, I'll be glad to share with any of you on this call. And I see Joan has her hand up.
Yes, so are all adults on Medicaid part of HealthChoices, or is that a choice?
HealthChoices is the Medicaid. There are some other, I should think carefully about this. Let me answer this in a way that I know is affirmatively accurate. HealthChoices is the Medicaid program for adults that are financially eligible for Medicaid. Many pre-existing waivers, such as the aging waiver and independence waiver, were consolidated into the Community Health Choices waiver. There are some waivers that still exist, I believe, through the Office of Developmental Programming, ODP, that would neither be HealthChoices nor CHC. But let me double check as to who exactly, what other Medicaid programs there are for adults, especially the waivers, so I don't misspeak.
Thank you.
Next slide, please. So as I mentioned, precision is key. For example, we mentioned this before, kind of with the UPMC for life, DSNP, and the UPMC CHC. Advice I always give consumers is certainly bring your cards, all of your cards, insurance cards, to the doctors, of course, and make a habit of explicitly stating, I have UPMC for life, or I have Keystone First HealthChoices. The Keystone First CHC wording similarity is something that drives me up the wall. Unfortunately, that was a point of successful advocacy 2 years ago when we reached out to the HealthChoices plan, Keystone First, and they were willing to put some language on their website saying, if you're looking for the Community Health Choices plan, click here. Because of course they're different websites because they're different insurance plans under different programs. But again, lesson learned is precision is key. Apprise hopefully is a great resource for consumers who go through this transition, because I think the Medicare side is certainly probably the more overwhelming than the CHC side. And no need to expand upon these billing errors because we've talked about them quite a bit. Next slide, please. So as I mentioned, the LIFE program still exists and is an alternative to CHC. LIFE, Living Independence for the Elderly, is Pennsylvania's PACE program, not to be confused with the pharmaceutical program. LIFE participants do receive information about CHC as an option if they're otherwise possibly eligible for it. And the independent enrollment broker is also the entity in which a person can start a LIFE program application with as well. Similarly to CHC, if someone applies for the LIFE program and is denied, they do have the opportunity to appeal that decision as well. And Joan, I see your hand is up. I'm not sure if that's from your last question or if you have a new one.
No, that's my last question.
Excellent. All right. Next slide, please. I see John has an actual hand up.
Yeah, David, just a simple question on the LIFE program. I had somebody that was in LIFE because of the single doctor and having tremendous problems with it, wanted to go back to CHC. I was reading your slide there with great interest. You can get into it, but it's a real difficulty to try to get out of it and go back to CHC. Any ideas?
Depends on the difficulty, especially what you're hearing. The ombudsman can potentially be of help. I know the ombudsman here at CARIE have helped some individuals who are dealing with LIFE providers that were, trying to put this diplomatically, inhibiting the process of that transfer. So the ombudsman could be a good resource. I'm curious, what do you know kind of where the pain points were in these cases you've experienced? Oh, looks like you're on mute, John. Still muted, John.
The LIFE program is located in Exeter Township in Berks County. The consumers were having tremendous problems getting the single doctor for their prescriptions. Also, if they had an issue with a particular sores or something that was needed attention quickly, they were really stuck. So they just wanted to get out of the LIFE program, and they were just being I'll choose my words really closely. I don't want to use the word bullying, but I will say that they were being given a very hard time to get out of the life. And, I'm just trying to figure out a way how they would be able to maneuver that system a little bit easier.
I would definitely refer consumers to your local ombudsman program. Yeah, that seems to be kind of similar experiences to what I've heard about here in Philadelphia. In terms of the best advocate for a life participant, I would say the ombudsman.
I had a couple of experiences. I'm not real high on life at all, principally because people have to travel to it and a whole bunch of reasons, and the resistance and lack of satisfaction that my beneficiaries had. Unknowingly, I simply said, I recommend that you enroll in a Medicare Advantage plan. And we went through and chose a plan, and I did an enrollment. And bingo, the next month, they were in the new Medicare Advantage plan.
Mm. Right, I know.
Peter, were they in life? Peter, were they in life?
Yes, they were.
Oh, okay, thank you.
Right, obviously mileage may vary and there are different life providers, right. But yeah, worth driving the point home that it is an available option, and the IEB and a program like a prize can still make sure people know that it is a available option. But yeah, between Peter and John and what I've heard, again, speaking kind of more off the record, it can definitely vary the experience. So there are different facets of the Community Health Choices program, and depending on someone's relationship to the program, some may be more familiar with different component areas than others. This is a fairly just high-level overview of different facets of the program that have many of which historically have had some challenges, especially in the fee-for-service Medicaid program. We can kind of talk about what we've seen with the transition to managed care. Next slide, please. Wanted to include a slide about nursing home residents, because as we mentioned, nursing home residents, there were some changes to what was made available to them. Worth emphasizing that all nursing home regulations still apply to all residents, and this includes having an appropriate care plan and care plan in place upon discharge, and of course receiving proper notice. Nursing home residents were the recipients of quite a bit of outreach from the Office of Long-Term Living and the IEB about the different plans available to them, and a nursing home, couldn't enroll a consumer into a CHC plan. Something that was more important and critical at the beginning of implementation phases across the state was that, much like other LTSS providers, nursing homes did have contracts with different plans. To my recollection, the vast majority of nursing homes had contracts with all three, though that was not universal. An individual had their choice of CHC plan and did have some special protections, an indefinite continuity of care period, if they have opted for a plan prior to implementation, and that plan didn't have a contract with the nursing facility. Long and short of it is there were protections in place to ensure that if someone chose an unaligned plan, that they were not denied services because of insurance issue. If someone does change nursing facilities from one to another in their CHC plan, which may have been accepted by the first facility but not the second, they do have a continuity of care period in which they can make that change. Another new feature, to call it as such, is CHC residents in nursing facilities that have CHC will get a service coordinator, which was not the case in the fee-for-service system. They help develop the person-centered service plan and coordinate care, which includes physical health care and Medicare. Now, nursing facility residents, report, I can talk about that in lessons learned. Another new feature for nursing facility residents is the inclusion of behavioral health services being a covered service, and they are provided through the existing behavioral health choices managed care plans. So this is exciting, and it is something that was made aware to nursing facility residents through some outreach, though, as we'll talk about later. The utilization rates for behavioral health suggest there's still a lot of work to be done. Nursing residents don't have co-pays. Nursing homes will continue to coordinate transportation, and the CHC plan will pay for bed hold days when a resident is hospitalized. So in the next slide, we can talk about some of the early lessons learned with nursing home residents. My mistake, thought there was a slide there I didn't include. Again, speaking about nursing homes, we've heard from a lot of ombudsmen that service coordination still seems to be a big issue. Nursing home residents report that the identity of their service coordinator is often unknown to them, or they may have received a visit from someone and it was not readily apparent to them that they were a service coordinator with their CHC plan. Not to downplay the significance of what a service coordinator can do, but within a nursing facility, residents are still working with the facility itself and the social workers to get the services they need. That being said, there could be some CHC benefits, long-term services supports that a consumer could get. So it is important that the managed care plans and advocates like the ombudsman can continue to help residents better identify who their service coordinator is, and just as significantly, how to get in contact with them. That transitions into care management, service coordination, and assessments. Worth emphasizing that care management and service coordination are different functions. Care management is available to all community health choices participants, whether they are receiving long-term service and supports or not. Generally speaking, care management is a set of activities intended to improve patient care and reduce the need for medical services. This could involve coordinating care, eliminating duplication of services, and otherwise helping consumers better manage their health conditions. The term itself, care management, is not explicitly defined for the CHC program. Care management, however, does not require that there is a written care plan for all participants, or more specifically, a person-centered service plan. All consumers who are eligible and are receiving long-term services and supports, they will get service coordination and they will get a person-centered service plan, which outlines which long-term services and supports will meet their needs. Here's a really key part. Service coordination is an administrative function of the managed care plans, meaning broadly that the different managed care plans have a fair amount of latitude as to how they deliver service coordination to their consumers. What we saw primarily in the early stages of implementation, despite some continuity of care periods for providers, different CHC plans took different approaches as to whether service coordination was going to be something that they contracted out to service coordination entities, or whether they'd be providing it in-house. So there's still language floating around as to whether someone is an internal service coordinator, meaning they're directly employed by the CHC plan, or if they're an external service coordinator. Their external service coordination entity has a contract with the plan. On paper and in theory, the services should be identical, should be the same. We've heard from consumers and perhaps observations from advocates and from providers themselves. Many folks will still have a preference, especially if you've got a specific service coordination entity that may have a history of serving specific populations, and may have more familiarity working with consumers with certain conditions or certain ages, populations, etc. Consumer, in terms of what choice and rights consumers have, they have the right of choosing their own service coordinator at any time. They may not necessarily have the option to choose a particular agency, however. A big pain point has been consumers being provided with inadequate information about prospective service coordinators. At worst, sometimes it's just been some names on a piece of paper. Some other instances, someone may have some more information. What is this person's caseload? How long have they worked? some other information that can help consumers make an informed choice. That's not universal across the board as far as we know. And that's something that consumers and advocates have been pushing for and advocating for quite some time. A comprehensive needs assessment is something that the MCOs will complete annually for consumers, and a consumer can also request a comprehensive needs assessment at any time. One also will be done after certain trigger events. For one example, a discharge from the hospital. And a person-centered service planning process must be completed no more than 30 days from the date of the comprehensive needs assessment. Next slide, please. Big problems with service coordination, as I mentioned. It can be very challenging to reach service coordinators by phone. To my knowledge, what's most common for each of the plans is for if a consumer wants to get a hold of their service coordinator, they may not always have a direct dial, a direct phone number. They may need to be calling their CHC plan and speaking with what's effectively their service coordination department. Staff person will kind of relay information from consumer to assigned service coordinator. Perils of this is sometimes, when expecting a call and, a few business days, they may not get that follow-up, or, consumers may just be so accustomed to having a direct dial that these added steps can sometimes be a little challenging or onerous. There's definitely confusion as to who an individual service coordinator is. This is for a number of reasons. Again, for people that are relatively new to this program, they may not be as hip or savvy to, what exactly a service coordinator is, and that some person might be their service coordinator. There's also just the reality of the workforce. Turnover rate is quite high, not just within the industry itself, but also with, especially in the past few years, contract terminations. So it was not uncommon for someone to, cycle through multiple service coordinators without, their say-so. Could just be that so-and-so no longer worked for the company, or someone's external service coordination entity had their contract terminated. All of this, of course, is to be kind of contextualized with, communication with the participant, letters in the mail, but all of these things can be either misinterpreted or perhaps, never come. And of course, there are some other concerns about the person-centered service planning process, as mentioned here for individuals with dementia, but again, the confusion about, who a service coordinator might be also can translate into confusion as to, what the process is. So it's an ongoing point of advocacy, and given that service coordination is an administrative function of the plans, it does require getting a better understanding of what each of the plans are doing themselves and advocating with them, as well as with the Office of Long-Term Living. In the interest of time, we'll go to the next slide. So a new feature with Community Health Choices is that all CHC participants have behavioral health coverage through Behavioral Health Choices. For those that were previously in the aging waiver, which was consolidated into the Community Health Choices waiver, in addition to nursing facility residents, this is a new benefit. So consumers can access peer counseling services, cognitive rehabilitation therapy, and other behavioral therapy services. And the link here is will identify which behavioral health MCO will serve which county. Next slide, please. As we can see from the data, it does seem to suggest that there's continued underutilization, which is clearly identified as a missed opportunity for better behavioral health care. We've spoken with and have collaborated with Community Behavioral Health, which is the behavioral health managed care plan here in Philadelphia, doing some outreach, letting people know that this is an available benefit. Given that there are some problems with service coordination, as we mentioned before, it doesn't necessarily come as a surprise that there may be some problems with communication about available behavioral health services and its availability. The CHC MCOs, despite not administering these services, they are the entity that's tasked with coordinating behavioral health care. If someone contacts their CHC plan, or they may speak with their service coordinator and they say, I'm feeling like I need to kind of access some behavioral health services, it's often presented in a probably very different way. the CHC plan or the service coordinator or whomever's, you know, kind of in contact with the consumer at the CHC plan should be the one to kind of facilitate that connection to the behavioral health managed care plan. Next slide, please. Transportation. In Community Health Choices, all participants get both emergency and non-emergency medical transportation. The Medical Assistance Transportation Program did not change and continued to provide non-emergency medical transportation to CHC participants. For someone who is looking to schedule non-emergency medical transportation, they will coordinate with the Medical Assistance Transportation Program in that person's county. And excuse me, MATP continues to be the payer of last resort. So someone would use MATP if there was no other program that they can use. And in terms of how MATP kind of provides transportation, this could be either through fare reimbursement, mile reimbursement, or paratransit. As a plug, if someone is interested in more information about transportation, I can actually just link in the chat here. We do have CHC transportation guide, which might be of some utility. For those who are receiving long-term services and supports, they also can get, sorry, I'm trying to post in the chat here. Sorry about that. In addition to the Medical Assistance Transportation Program, nursing facility clinically eligible participants can also get non-medical transportation, provided it is outlined and included in their person-centered service plan. So for example, if someone is working with their service coordinator and they identify that it is, you know, important for them to go to church every week or to go to the club to play bridge or go to the casino or wherever, if that is kind of identified as their goal and priority, then they should be able to get some non-medical transportation services included in their PCSP. Next slide, please. If anyone has ever worked, either utilized themselves or worked with consumers who are trying to access, you know, different transportation services, the normal problems continue, but certainly no worse under CHC than previously. The CHC MCOs do use transportation brokers to help with coordination. And we're identifying that, you know, direct care workers often provided transportation in rural areas. And at least in the past few years, the Office of Long-Term Living has been evaluating ways to help sustain these informal transportation supports. You know, recognizing that, you know, here in Philadelphia, you know, the transportation options are a bit more robust than in more rural pockets of the state. Again, in addition to the transportation roadmap outlined in the chat, my colleague Ren Chenoweth is our transportation advocate. And if you do have any questions about Community Health Choices transportation or transportation in your county, certainly feel free to either let Rebecca or Dan know or let me know and we can connect you to her. Next slide, please. As I mentioned before with the IEB, we can briefly talk about the functional eligibility determination. Aging Well, in partnership and contract with the independent enrollment broker, completes the FED, which was the tool that was implemented in April 2019. The FED, again, is an algorithm that's used to help determine clinical eligibility in addition to something like a physician certification form. Someone's deemed either NFCE, nursing facility clinically eligible, or NFI, nursing facility ineligible. If there is a discrepancy between the FED assessment and physician certification, this triggers an automatic review by the Office of Long-Term Living medical director staff. Once someone is enrolled in the CHC program, sorry, I need to silence my phone. I'm getting more spam calls lately. Once enrolled, another assessment tool, it's called the Inter-RAI, is used for the comprehensive needs assessment. And the MCOs have latitude to use some additional tools as well. Next slide, please. So as in terms of early lessons and tips with the implementation of the Fed, this is still actively reviewed and monitored through some statewide stakeholder groups. But one point in particular, we can see that advocacy resulted in adding a question to the Fed tool about veteran status and adding more inclusive questioning as well with regard to gender options. And as mentioned here, there are concerns, especially when the Fed was initially implemented, whether it was an accurate tool for determining whether someone was nursing facility clinically eligible or not. There is a 3-day look back period, and a particular concern was whether this can accurately assess those with cognitive impairment. It's possible that someone could have, periods of relatively well functioning, but beyond that 3-day look back period, there could be instances where someone really is in need of these services and the tool is not necessarily capturing that. That cannot be definitively said though. And like I said, the Fed tool, its continued implementation and its operationalization to this date is still something that's looked at by advocates and of course the state as well. Next slide, please. Nursing home transition is again another administrative function of the managed care plans under CHC, and they're required to provide it to residents who are seeking it out in nursing facilities. Much like service coordination, CHC plans can continue to contract with NHT providers, provide NHT themselves, or adopt a more hybrid approach. The plans all offer extra financial support, and the exact amounts will vary as some of those value-added benefits that the plans have. Next slide, please. NHT continues to be a challenging process for someone who's seeking to transition from a skilled nursing facility at home to the community. Many barriers can exist, whether it's available housing or securing services in place. Something that happened relatively recently was a program improvement in early 2019 in which the Department of Human Services finalized procedural changes to inform residents of their eligibility for waiver services approximately 2 weeks before pending discharge. Prior to this, someone could have been eligible to receive care and support in a nursing facility, but not necessarily eligible to receive waiver services at home. This procedural change added some clarity to this process and would allow for home and community-based service eligibility and subsequent services to start on the day of discharge. Previously, there could be some gaps, which obviously if someone is in need of these services, these gaps in services can lead to really adverse outcomes. Next slide, please. All right, getting towards the end here. Under Community Health Choices program, back in 2016, CMS did issue new Medicaid managed care regulations that now include managed long-term services and supports provisions. This was mentioned, I believe, previously in a slide, but I didn't state as such. Community Health Choices is a managed long-term services and supports program, or an MLTSS program. These MLTSS regulations include complying with person-centered planning and home and community-based service settings regulations, stakeholder advisory groups, and creating a beneficiary support system. For the Community Health Choices program, the University of Pittsburgh Health Policy Institute is actively evaluating community health choices on an ongoing basis. They recently presented an update on their research at a stakeholder meeting. For whomever is interested, I can include that as a follow-up email as well. And lastly, performance measures are collected and reviewed by DHS. So if someone, things like when assessments are completed or how complaints are resolved, and even just the quantity of complaints, these are reviewed by the Office of Long-Term Living as well. Next slide, please. Complaints and grievances. Complaints, first and foremost, consumers can complain about any problem that they're experiencing in the Community Health Choices program. A complaint is a dispute or objection regarding a participating healthcare provider or the coverage, operations, or management of a CHC plan, which hasn't been resolved by the CHC plan and has been filed with them. This could be a denial because the requested service or item is not a covered service. Someone or a CHC plan may not have provided a service or item in a timely manner, etc. A grievance, however, this is a request to have the CHC plan reconsider a decision regarding the medical necessity and appropriateness of a covered service. So if someone is getting a notification from their CHC plan that their personal assistance services are being reduced and they want to appeal that decision, that would be going through the grievance process. As I mentioned before, if someone does get one of these notices, if there's any change to their LTSS, that would be fewer services, they have certainly the right to appeal, and they can contact free legal aids for assistance, and free legal aid information can be found on those notices. Next slide, please. Beneficiary support system is something that will help, again, consumers better understand what rights they have in the system and resolve issues. But CARIE has been advocating for an independent CHC ombudsman, but at this time, there are no plans for the implementation of that. As we mentioned before, with the issues, the LIFE program, other CHC participants in nursing facilities, assisted living, personal care, adult day, and dom care should continue to reach out for the long-term care ombudsman to assist, not necessarily just with CHC issues, but other care and quality of life concerns in those settings. Next slide, please. There are ample opportunities for stakeholder engagement. I won't talk about this too much because I want to get to questions soon. There's a CHC advisory committee that manifests as a managed long-term services and supports subcommittee of the medical assistance advisory committee. These are monthly meetings. I'm a committee member on this group. And this is an opportunity for the Office of Long-Term Living to provide updates to stakeholders, advocates, and consumers, to hear from plans themselves and from other stakeholders to provide updates on the program. This Thursday, we actually have a listening session of CHC consumers who are talking about how COVID-19 has impacted their experience with community health choices. DHS, these third Thursday webinars, I actually need to double check that they're still doing them. This is actually a slide I might need to update. There are also a number of different listservs for different stakeholder groups to get updates regarding changes to the program or clarified guidance. There's a CHC mailbox, and within the plans themselves, there are what are called participant advisory committees, or PACs. These are opportunities for participants themselves to participate in some advisory capacity. And it's a requirement that each of the plans must create a PAC. And for those interested, we have an advocacy journal and more information about PACs for each plan, which can be sent out as an email after. Next slide, please. Here's the contact information for the different plans. Again, AmeriHealth Caritas and Keystone First CHC. Keystone First Community Health Choices is available in the Southeast Zone, which is the southeastern portion of the state. Throughout the rest of the state, the plan is known as AmeriHealth Caritas and PA Health and Wellness and UPMC. They can be contacted by phone, and more information about the plans themselves can be found on their website. Next slide. Here are a number of other different resources. I've already got a list of the things I will follow up with you all about, but certainly if you have any questions about community health choices and wanted to research yourself, I encourage you to visit our website, carie.org/CHC. We keep that regularly updated with consumer-friendly educational materials. We have a very comprehensive advocates guide and some other consumer supports as well. Transportation roadmap, information about PACs, and some recordings of past webinars and town hall forums that we've held. Next slide, please. Another plug for our advocates guide that can be found on our website. This is our most comprehensive guide that can serve as a resource if any questions do arise. Next slide, please. You certainly know where to find us here at CARIE. No need to belabor the point here. I think the next slide is illustration for questions. I know we've answered quite a few during the presentation. I will quick take the opportunity to thank you all for your interest in learning more about this. I hope it did provide you some update as to how things are going, not just that we are in a steady state with a fully implemented program, but how things have evolved with the pandemic. If questions arise after this presentation, I'm sure you all have my information, or Dan or Rebecca can provide it. But before we close, I'm wondering if anyone does have any questions or comments.
David, it's John. Do you know any length of time when the MCO contracts are up?
I don't know that off the top of my head. I'll have to double check.
I know there was a lot of question about the IEB, and I know that Aetna at one point in time was going to bid, but I don't think anybody can outbid Maximus. But the MCOs themselves, I'm just wondering, because we're going into the third year of the contract. Yeah, third year of the contract. I'm wondering if there's going to be a change.
That's a good question. I don't know off the top of my head. I'll have to take a look and get back to you.
David, you had said you were going to post something about the percentage of duals that were in D-SNPs, et cetera, but that did not get posted on the chat.
Yeah, it looks like it somehow just went to Dan Lewis specifically. Sorry about that. Just posted it to everyone.
And are we going, can we get these slides? Are we going to get these slides?
Sure. Yes, I have no qualms with that. I'll make a few edits that I saw need to be made, and then I can give them to Dan or Rebecca, or otherwise just send them to you all.
Thank you.
Any other questions? All right, wonderful. Well, thank you, David. It's been extremely informative, and thank you for the time and dedication here, and everybody, thank you for paying attention. Thank you for being active. I myself have found this to be quite beneficial, and you know, I learned something, so I hope all of you did as well. And David, yeah, if once you make the edits to the slides or have any resources that you want to share, you can send those over to me, and we have a distribution list that I can make available to everybody.
Perfect.
This is also being recorded. I will stop the recording in a second so people don't have to hear me talk too much. And we will get that up on the YouTube channel and have that link sent out to everybody for your viewing pleasure in the future. So with that, again, it was good to see everybody. David, thank you. And any other questions that any volunteers have, you can feel free to send them over to me, and I will pass those along to David as seen fit. Everybody enjoy the sunshine, enjoy the weather. And David posted his email there in the chat, johnson@carie.org. And
yeah, Peter, John, I know you talked about your CHC experiences in your counties. Yeah, if anything novel comes up, I'd love to hear about. We talk about it quite a bit in our prize meetings. Seems like we're going through some similar issues, but John, you specifically talking about kind of inter-county, which makes a lot of sense, you know, going to Philly for Will's Eye or something. Yeah, if you have the time and bandwidth and something novel comes up, we'd love to hear about it.
You got it.
All right, thank you.
All right, take care, everyone. Enjoy the rest of your days.